Linda Homan is the Senior Manager of Clinical and Professional Services for Ecolab Healthcare. In that role, she focuses on the development of clinical and educational solutions, applied clinical research, and incorporation of clinical best practices in all healthcare offerings. Linda is a registered nurse, is board certified in infection control, and has been active in the field of infection prevention and control for over 20 years. Linda has participated in the development of infection control and environmental hygiene guidelines for the state of Minnesota and for AHE, and has often presented on topics related to infection prevention and control at regional and national APIC, AORN, and AHE meetings. Linda, and I'll turn the floor again over to you with hopefully no audio issues.
Great, thank you. Thanks everybody, and we'll just try this again. So hopefully you can all hear me just fine now. And I'm anxious to talk to you today about the science of compliance. So I'll just get started. Let's see here. There we go. So our objectives for today: describe the impact of noncompliance with horizontal infection prevention measures, and then we're talking specifically about environmental hygiene and hand hygiene today. 2 is to discuss the behavior models and methods that can promote compliance. So we'll talk a little bit about human behavior models, traditional methods that we use today to improve compliance, and some behavior modification ideas and some recently published studies in this area of behavior modification related to infection control. And then we'll review methods to measure compliance for both environmental hygiene and hand hygiene. So with that, we'll get started. And the first thing I want to do is talk a little bit about what horizontal infection prevention measures are and what the impact of that is, of noncompliance is on those measures. So maybe a lot of you haven't heard of this, but when I read this, this article by Wenzel and Edmond in the New England Journal of Medicine a couple of years ago, it really resonated with me as an infection preventionist. There are 2 basic approaches, according to them, to think about infection prevention. There are vertical methods and there are horizontal methods. And the goal of a vertical method is that it's pathogen-based. It's intended to reduce infection or colonization due to a specific pathogen. So think of MRSA or C. difficile. Horizontal measures are population-based, and they're intended to reduce all infections. So for vertical measures, they're generally very selective for the specific organism that you're looking for. The resource costs can be high at times, and examples are active surveillance, nasal decolonization, or isolation procedures that are specific to an organism. Horizontal measures, on the other hand, are generally universal. They're generally lower in cost, and examples might be hand hygiene, environmental hygiene, and care bundles. And horizontal measures are consistent with what the patient wants, if you think about it, because they really want to avoid all infections, not just those that are due to specific organisms. But the downside of horizontal measures is that they often require modification of behavior of healthcare workers in order to be effective. And so horizontal infection prevention measures are very valuable, and in some ways I think we've gotten away from them a little bit over the years because we have more and more emerging pathogens that we're dealing with, and we focus on how to deal with that specific pathogen, and sometimes in the past without thinking of just the things that we need to do every day to prevent infections in general. And so successful hand hygiene and effective environmental hygiene are horizontal approaches to infection prevention. And as we know, there's a continuous flow of pathogens from the patient to the healthcare worker to the environment. Patients with pathogens contaminate their environmental surfaces, and then those pathogens become a source for healthcare workers to contaminate their hands or gloves, and then the contaminated surfaces can contribute to the spread of HAIs. And this cycle just goes around and around, and there's this continuous flow of pathogens in the environment. And we all know this. It's just something to sort of ground us. The important thing to know about this then is that these pathogens survive on environmental surfaces for a long time. And so this is from a pair of studies that were published a few years ago where they determined how long these organisms can live on surfaces if they aren't removed appropriately. And so right at the top of the list is one of our biggest problems these days, which is C. difficile, which can survive for more than 5 months on environmental surfaces if not removed. Staph and VRE also survive for long periods of time, as does Acinetobacter, and these are pathogens of concern in healthcare and things that we need to be aware of. And so just to think about the fact that if we don't manage these and we don't break that chain of infection, these pathogens are going to be waiting there for an opportunity. And so we have thought traditionally that the hands were the most important thing when it comes to the transmission of pathogens, and that touching a patient's skin was more likely to create contamination than touching the environment. But this study that was done in 2011 showed that hand contamination was equally likely to occur after contact with touching the environment as it was with touching skin. And more importantly than that, there wasn't really any significant difference in the number of colony-forming units that were contaminating the hands after touching skin versus environmental surfaces. So these two graphs here are showing that essentially the amount of contamination on your hands is equal whether you touch skin or environmental surfaces. So really kind of creates an equal playing field when you think about it in terms of the importance of hands versus environment, which is why I feel it's important to think of them together. Another study that was done in 1996, this one's a little bit older, showed that healthcare workers who had no direct contact with a patient but touched bedding or objects in a room can contaminate their hands. And so on the left side, it's the number of environmental surfaces in a patient's room that tested positive. And then on the right side is the percentage of healthcare workers' hand cultures that were positive for C. diff. And you can see that in a room where none of the surfaces tested positive, obviously none of the healthcare workers' hands tested positive for C. difficile. Whereas if you go to the room where more than 50 objects were contaminated with C. diff, 36% of the healthcare workers walked away with hands that were contaminated, and that was after no contact with the patient. So the more surfaces that are contaminated in a room, the more likely that a healthcare worker's hands will be contaminated as well. And then this is another study that talks about the transmission of MRSA from environmental surfaces to hands. So this is, the last slide was about C. diff, this is about MRSA. And so in this study, 42% of nurses who had no direct patient contact contaminated their gloves by touching objects in the rooms of patients with MRSA. These volunteers touched bed rails and overbed tables in the rooms of patients that were not in contact precautions. And in that group of people, 31% of hand cultures yielded Staph aureus. And in volunteers who touched surfaces in rooms that had been terminally cleaned, only 7% were positive. But nevertheless, even after the room had been terminally cleaned, 7% of handprint cultures were positive for Staph aureus. So healthcare worker hands are contaminated even when they don't touch the patient. So now thinking about your hands and how to break the chain, what's the impact of human behavior? So we've seen that these surfaces are contaminated. We see that touching them contaminates our hands. And so what's the impact of human behavior on this? And so for healthcare workers in this study by Dr. Donsky, he showed that healthcare workers' ungloved hand was cultured after they had performed an abdominal examination of a patient that had MRSA in his nares. And then they did a hand plate culture, and you can see that the culture on the left side with the pink handprint is from touching the patient's abdomen. And again, a patient who was only colonized with MRSA in the nares. After the healthcare worker's hand had been cleaned with alcohol foam, another handprint was obtained, and the resulting culture was negative for MRSA. So obviously, MRSA is susceptible to alcohol-based hand rubs. Alcohol-based hand rubs are an effective method. So if we know that we're touching something that's contaminated and we use hand sanitizers, we can be reasonably able to expect that our hands will be decontaminated. So what about disinfectants? This is a set of studies that looked at the failure to remove MRSA from environmental surfaces, and they found that it's most likely due to the failure to clean the surface, the failure to apply the detergent or disinfectant for the adequate contact time, the failure to apply it at the proper concentration, or that they attempted to disinfect without cleaning first. And so these are not measures of the efficacy of the disinfectant, but rather of the practice of the person who's applying the disinfectant. So my point in making this is that MRSA is susceptible to those in-use concentrations of EPA-approved hospital disinfectants. And so it isn't the product that's causing the problem in this case, it's the way that the product is applied. This one is talking about C. difficile, and so just to make the point again that the disinfectants themselves can be effective in decreasing the transmission of C. difficile. So these are two different studies that looked at the environmental cleaning can reduce the transmission of C. difficile. In the first one, during an outbreak of C. diff infection, disinfecting environmental surfaces with a bleach solution decreased contamination of surfaces to 21% of the initial levels and halted the outbreak. And in the second study, they employed environmental monitoring, use a fluorescent marker, house-wide daily use of a hydrogen peroxide, peroxyacetic acid disinfectant, and EVS staff training, and they were able to decrease their hospital onset C. difficile significantly over 6 months' time. And so the point of this is that there are EPA approved, EPA registered, I should say, disinfectants that are effective sporicides against C. difficile at in-use concentrations. And so we've shown that the hands can become contaminated by the environment, that hand sanitizers and disinfectants are effective. And so what is the challenge that we have? We know there's a continuous flow of pathogens. We know that they're effective, so why do we still have a problem? In many cases, it's because of compliance, or it's because of human factors or human error. And so I just want to talk a little bit about how we can promote compliance. And in order to do that, I have to step back and give you a little overview of social cognitive models for compliance. And this is health belief models. So there are several models that are out there. The first one is the health belief model. There's also a protection motivation theory, and then there are 3 others. The one I'm going to focus on today is the health belief model. It's really quite well used and well accepted in the healthcare field. And it's based on the fact that people are evaluating the threat. They're evaluating the threat to themselves, and it's really focused on their perception of the threat. They developed this theory to explain why some people don't use health services like immunizations and screening. And so the person, what they find in this health belief model is that a person is more likely to adopt a recommended action, such as a vaccine or such as hand hygiene, if the perceived susceptibility is high, and the severity is perceived as being high, and if the benefits and the benefits are high, and if the barriers to doing the recommended action are low. And so all the time that we're thinking about whether to do an action, whether to do hand hygiene, we're looking at the perceived susceptibility that we have to it, how severe the threat will be to us if we succumb to it, how good the benefits are to what we're doing, and how low the barriers are to doing what we're being asked to do. And so I'm going to talk a little bit about the health belief model and what we're looking at. So the whole time that you're deciding whether to wash your hands or whether to get a flu shot this year, these are the things that are going on in your mind. You're looking at perceived susceptibility, perceived seriousness, the cues to action, whether they're internal to you because you knew someone who had the influenza and so you want to avoid that, the external cues to action where you're being asked to do it, you're being rewarded to do it at work. What are the perceived benefits? What are the perceived barriers? What's my ability, my self-efficacy, my ability to do the thing that they're asking me to do? What's the social pressure that I'm up against to do this action? And what's my intention to perform the action? And so this is a lot, so I just took this and broke it down and put one slide in for each one of these things to try to better explain what they are, and this will go pretty quickly. But the perceived susceptibility is your opinion of the likelihood of acquisition of disease. And so you might be thinking as you're doing an action, what is the likelihood that not doing this is going to cause disease? So what's the susceptibility of either myself or the patient in this situation? The second one is the seriousness, my opinion about how serious the condition is and what its sequelae are, what the outcomes might be. And so for yourself and for your patient, you're always evaluating that in your mind, unconsciously really. What are the cues to action? Are there strategies to activate readiness to act? Are there human factors engineering things that have been put in place to make it easier for you to act? The examples here on the top are someone who uses blue cloths in the patient room to clean a room and yellow cloths in the bathroom. And so those are strategies to activate readiness to act. To use the right cloth in the right situation, they're color-coded. The example on the bottom is human factors engineering. You put hand sanitizer at the point of care so that people are more likely to use it. What are the perceived benefits? What's my opinion about the ability to do what they're telling me to do to reduce the seriousness of the risk or the impact? So this little bubble here says, I think using hand sanitizer will help keep my patient from getting an infection. And I would actually turn that around and say, in some cases, we're making a decision based on our own susceptibility. I think a lot of us who work in infection prevention understand that healthcare workers are more likely to wash their hands on the way out of the room than on the way in some cases, because they are protecting themselves from whatever they might have come in contact with. And so it's your opinion about the ability of that action to reduce the risk or the seriousness of the impact. The next thing is a perceived barrier. So this is my opinion about how real and how about how the tangible and psychological costs of the action. So the person on the left is thinking that they don't want to touch any buttons because it's going to make an alarm go off and the nursing staff will get mad at them. And so they're evaluating the likelihood that they're going to have tangible and psychological costs by doing what they're being asked to do. The person on the right is saying we don't have time for hand hygiene, and that might be the right answer to that question depending on the situation they're in, but they're making these kind of decisions all the time. Self-efficacy, my confidence in the ability to do the action that I'm being asked to do. Social pressure, the perceived pressure to engage or not engage in a behavior. Someone will notice my exceptional compliance in using this hallway dispenser, or to turn it around, someone's monitoring me, someone will notice that I didn't wash my hands and so I better do it. So there is social pressure that's applied. And then the intention to perform the action. So what's the individual's readiness to perform the given behavior? So I would say I intend to wash my hands every time I go in and out of a room. It's a habit for me. It's my intention to perform that action, and I will do it unless something comes along to change that intention. So that's a quick overview of what the health belief model is. And if you think about it, we're balancing this every day in healthcare, not only for our own health, but for the health of our patients. And so this is an important thing that that motivates people to behave a certain way. And so we have to be thinking about how we can impact those things, how we can remove the barriers from those perceptions and try to make it easier for people to make the right decision. Some other things that we have to think about when we want to promote compliance is that there are other factors that affect performance of hand hygiene. And so that's role, my role, how much time I have, how many distractions I have in the environment, what's the accessibility of hand hygiene, what condition my skin is in. We all know that when people's skin becomes dry in the wintertime, it gets harder for them to want to use hand hygiene because they think it's going to make their skin worse, even though studies have shown that using alcohol hand sanitizers does not deteriorate the condition of your skin. Glove use, education, products, these are all things that affect performance of hand hygiene in addition to those human factors that we just talked about. So a lot's going into those decisions even though they're not thinking about it. This was a study that was published this last summer in the American Journal of Infection Control, AJIC, and I thought it was really interesting because it measured the daily number of hand hygiene opportunities and compliance by role, and they looked at over 20,000 hand hygiene opportunities on a med-surg unit. They found that nurses have 3 times more hand hygiene opportunities than physicians, and yet they have 1.5 times higher compliance than physicians. I know that that's not a surprise to a lot of you out there because we all sort of anecdotally know that hand hygiene isn't as good in physicians as it is in nurses and other healthcare workers. But this study clearly showed that hand hygiene compliance in physicians can't be explained by the burden of how many hand hygiene opportunities they have. They have fewer opportunities, but they still don't wash their hands as often as they should. So role plays a big factor. And then there are factors that affect environmental hygiene as a strategy as well. The education of the person, the training of the person who's doing the job, how much time they have to do a good job. People are under so much pressure these days to turn rooms over quickly, to get in and out, and that has an impact on how well they can do their job, how well recognized they feel in their job, what tools do they have, and what products do they have to make the job easier. These are all things in addition to those human factors we talked about that play into a person's willingness or ability to do the job well. And so after all of that, what can we do to improve compliance? What are some methods to improve compliance? We have traditional methods, and we're all familiar with these. If you've tried to improve hand hygiene in your facilities, or if you've been involved in any campaigns to do any kind of quality improvement, we look at different ways that we can motivate people to do the right thing. So we have motivational programs, we have administrative measures, and we have training, and just a little bit about each one of those. So for motivational programs, you can use real-life examples. People resonate very well. If you have someone who gives a presentation at a huddle meeting about the impact of an infection on them or on their family, it has a bigger impact than just talking to them about doing the right thing. The other thing that some facilities have tried with success is to have patients and families participate in the activity. So trying to motivate people to change behavior. This is an example, actually, of an obituary, an actual obituary that was published in 2006. And this was used by someone to try to motivate folks. And they're talking in the actual obituary itself about hospital-acquired infections. And they say these are not numbers on month-end reports. These are our fathers, our mothers, our children, and our dear friends who are dying because of unclean hands. The little bit of extra time that it takes for healthcare workers to wash or to use an alcohol sanitizer is a pittance compared to the waste of so many productive, loved, and loving lives. And so if you used this in a presentation, if you used it in a meeting, if you chatted with people about it at casual meetings and showed them in something like this that's a real-life example, it sometimes helps motivate people. So those are some examples of that. There are also institutional or administrative measures that you can take, something that comes from the leadership, that comes from the entire hospital from the top down. And so we all know that if you have a champion at the top who's really driving an initiative, you're going to have a lot more success in that initiative if it's known to be important from the top down and if it's reinforced from the top down. So things like institutional priority, rolling things out as a facility-wide implementation program, and again, monitoring and feedback has to fit in there, because if you're not making an administrative measure of continuously monitoring and providing feedback for any quality improvement thing that you're trying to do, you're not going to be able to effect change. And so it's really important to have leadership from the top down. Training, I mean, as infection preventionists and other healthcare professionals, environmental services directors, we train, we retrain, and we train again. And this isn't to say that training isn't important, because it really is a critical function. And you really do have to train, retrain, and train again. People need to hear things many times and experience things many times before they learn. And so it's important to retrain and to reinforce it all the time. Educational programs have to address things like who expects them to follow these practices, what are the benefits, again, what's the health belief model. This helps them understand what's in it for them, what's in it for the patient. When is hygiene indicated? Where are the tools and products located? Why is it important? And how to perform hygiene practices. So this kind of training that gets reinforced in lots of different ways is really helpful and really has to be done. So then there are some other things that we have. There's been more and more talk about behavior modification methods to try to get people to think about hand hygiene. We all know, or environmental hygiene, we all know that if you put a hand hygiene sign up in the break room, after a while, after maybe 2 months, people don't see it anymore. They've read it, in the last 60 days and they aren't looking at it anymore. And so doing things like rotating signage can really help to reinforce things and sort of get it back to the top of your mind. Here's a good example. When I ride on the plane, and I fly a lot, they always have the message about the safety features and the things that you have to do to be ready to fly. If you fly on Delta, they had videos that were funny, and they would tell you the same information, but every time you came on the plane, you might have a different tape looping that would tell you the safety information, and you would pay attention because you hadn't seen it before and you wanted to see what was different this time. And so rotating the information and the way it's presented has a really good impact on people to get them to listen to something that they might not want to listen to otherwise. Recognition programs are important. People like to be recognized, and that's just a really important thing. Positive deviance, which is finding the person or people in the facility that are doing it right every time and using them as the example and taking their process and repeating it for others. Patient empowerment can work in some cases. Peer mentors are helpful to keep people on the right track. And then again, endorsement by authority figures. These are all important things to increase behavior, to change behavior that have been shown to be effective. There are a couple of studies that were done in the last year on this very thing, behavior modification to improve hand hygiene. And some of you may have seen this. It was published in the Journal of Health Psychology in January of this year. And they did a study where they tried various things to improve hand hygiene. And in this study, they had 15% of staff and visitors that were washing their hands at a particular hospital. And they found, they put images of people's eyes over the dispensers. They put women's eyes, they put men's eyes, different people's eyes over the dispenser. And this is the actual picture that they used. And they found that by putting the image of the man's eyes over the dispenser, it boosted hand washing by 33%. It wasn't as effective to put a woman's eyes over the dispenser for whatever reason. But this picture of man's eyes improved hand washing. And then they also found that putting a citrus smell around the sanitizer saw a 50% increase in hand washing. Now, there are people who that might not be effective for, and there are people who have allergies and things that you need to be aware of. So perhaps the citrus smell isn't going to be effective everywhere. But this was an interesting study and something that I think shows that we're really trying to find ways to change people's behavior, to get them to think differently, or maybe to unconsciously change their behavior. This was another study that was done on hand hygiene this year and published in AGIC, and their objective was to address the conspicuity, which is a word I had not heard of before, because I would say conspicuousness, but apparently that's not a word. So to address the conspicuity of alcohol gel dispensers, so to try to make people more aware of where those dispensers are. And I believe this was actually in common areas of the hospital, so the lobbies and places like that where they wanted visitors to see where the dispensers were. They affixed the flashing lights to the hand sanitizer dispensers for 6 weeks, and they compared compliance at the beginning and the end. And they found that the flashing lights improved hand hygiene compliance from 11% to 20%. And this was unchanged over 6 weeks. And they also found that brighter lights were more effective than less bright lights. I mean, it's only a 6-week study. It's not definitive by any means, but it just sort of goes to show you that you have to sort of start thinking outside the box of ways to attract people's attention and ways to drive people to do the things that we want them to do in healthcare to protect patients and protect themselves. And then the last thing that you can do to help in this area is human factors engineering. And that's the interrelationship between humans, the tools they use, and the environments in which they work. And so thinking about the work patterns of people and trying to put things together in a way that helps them with their workflow. And if you're asking them to take a step, do something like hand sanitizer, then try to incorporate it into their workflow and make it so that it's something that's easy for them to do. So in the medical profession, sometimes we use blame to encourage proper performance, and personal responsibility and training are often what we talk about, and we've just spent some time talking about that. But don't forget to look at the design of the system. What's the environment that they're working in? What's the organization or the process that they're working in? What kind of technology can we provide for them to make their job easier? And what is the task that we're asking them to do? If you take the time to evaluate that, you might be able to put some human factors engineering steps in place that will make people more likely to do the right thing. And so how do we change in terms of human factors engineering? Don't look at error as in compliance as a human problem all the time. Sometimes it's a systems problem. Sometimes it's a process problem. Don't make it worse by punishing people. It just creates an incentive for people to conceal their mistakes. It just tends to make people want to not tell people about mistakes. And we've had a lot of talk about this because of the patient safety movement that started in the late 90s. Punishing really doesn't work. Use technology and tools to enhance the task and make it safer whenever you can. Build in stop checks, build in affordances, do whatever you can to try to make the job easier. Whenever there is a near miss or an accident, learn from the mistake. Again, don't blame or punish people, but use it as a learning opportunity to change the process, to change the workflow. And then all of that is going to create a culture of support that's going to make it easier for people to want to work with you to improve the process. So we talked a little bit now about these different compliance methods and the behavior behind it and the psychology behind behavior. And so now I want to talk about compliance monitoring and feedback. And the point of this is just to say that if you don't understand where you are, if you don't understand your current process, you aren't going to be able to improve. And so we have to be able to monitor compliance so that we can figure out what steps to take to improve it. So feedback creates accountable people who ask for and offer feedback. So it creates a loop. If you're giving feedback to people, they care about the results, and then they ask for results, and they provide results to other people, and it just creates a really good positive cycle. So feedback, when given correctly, can really drive a positive change. So I'm going to talk a little bit about measuring hand hygiene compliance and the methods that are out there today for measuring hand hygiene compliance. The World Health Organization has a multi-modal hand hygiene improvement strategy that many of you are probably using in your institution. And when you look at this, it follows the basic quality improvement structure that we use for any problem we have in healthcare. Step one is ensure that you're prepared in your institution to do this initiative. Make sure you have the leadership in place, make sure you have a clear strategy, make sure you have the right resources in place to be successful. And take the time to do that up front because you'll be more likely to have success. Step 2 is conduct a baseline evaluation. You have to understand your current practice, what the people's perception is of that practice, how knowledgeable people are, and what's your infrastructure to support hand hygiene. So having a good baseline understanding of your state of the art at this moment. Step 3 is to implement the improvement program. So make sure you have things available at the point of care, provide staff education and training, do lots of well-publicized events involving endorsement or signatures from leaders. Driving it from the top down is really important. And so this is really an important step, is having that leadership in place. And then, just like any other quality improvement program, assess the effectiveness of the program, make adjustments, and go on. And it's a continuous cycle of reviewing your outcomes and changing. And the overall aim is to make sure that hand hygiene is an integral part of the hospital culture. And so this is what the World Health Organization says about an improvement strategy. When you're looking at how to monitor for hand hygiene compliance, you have a lot of factors to consider. We all feel that we need to monitor hand hygiene compliance, but we don't all have the same access to resources or have the same leadership involvement in it and ability to do it. But these are some of the things you need to look at when you are looking at hand hygiene compliance. What's the HAI status in your facility? What hand hygiene initiatives do you have going on today, and how would any new monitoring program fit into that? Do you have agreement from the top of the organization? What's the cost per room or bed that you can afford or that you are willing to spend? You have to look at the compatible IT infrastructure, and you have to look at whether it's important to you to have individual compliance data or group data. And I'm going to go into a little bit more detail about all of that in a minute. For accreditation, all hospitals have to implement a program that follows either the CDC or the World Health Organization hand hygiene guidelines. They have to set goals for improving compliance, and then they have to improve based on those established goals. We have to show continuous movement toward improvement. And you have different options, and those options that are available are direct observation, which is the secret shopper method where hand hygiene moments are recorded by an observer. You can have product usage measurement, which can be done either manually or electronically to track how much product is used as a proxy for compliance. Or you can do electronic monitoring, which is a technology-enhanced solution that delivers really specific data around who, where, and when hand hygiene events are being performed. And so I want to talk a little bit about the advantages and disadvantages of each of those. And I took this information from a document called Innovations in Promoting Hand Hygiene Compliance, and it's on the AHRQ website, so you can go there for more information. This is the information that they provide about direct observation. So they describe it as direct observation of hand hygiene practices, actually literally observing people. It can be a pen and paper model, or it can be technology-assisted model. There are new methods of technology-assisted direct observation becoming available all the time that can take that pen and paper report gathering and entering piece of it and make it easier. And so that's something to think about, is if you want to do direct observation, there are technology-assisted direct observation methods available to you. The advantages of direct observation is that it's the only method that can evaluate all 5 moments of hand hygiene today. It's considered the gold standard method because you can also monitor technique. So it's a very important method for the fact that you want to monitor, did they wash their hands long enough? Did they use the right technique? Did they clean all the surfaces of their hand correctly? So it's the best method to evaluate technique. Some of the disadvantages is that it has a likelihood to have a Hawthorne effect, which means that if I know you're watching me wash my hands, I'm going to do it at the right time, and I'm going to do it as well as I can. And so then your data isn't necessarily accurate. And that's especially true with the manual method. Some of the technology-assisted direct observation devices are based on an iOS or Apple-based device, and so a person looks as if they're looking at their iPhone when actually they're monitoring for hand hygiene compliance, and that helps eliminate some of the Hawthorne effect. One of the other challenges for direct observation is the inter-observer agreement. In other words, inter-rater reliability. So I have to ensure if I'm going to use the direct observation method and I'm going to train my my nursing staff on the units to do hand hygiene observation, I have to ensure that they all interpret the information the same way and they all collect the data the same way. Otherwise, my data isn't as accurate as it could be. Another disadvantage is that it's time intensive to observe and manually create reports if you're using the pen and paper method in particular. You have shorter observation periods and you're capturing really only a fraction of hand hygiene opportunities. So you're not capturing the whole universe of opportunities, you're capturing a subset of that. And so those are some of the disadvantages to direct observation. And yet, because you can monitor technique, I believe it's going to remain an important piece. We're always going to have to do direct observation so that we can give people feedback and training on the spot about their hand hygiene technique. But there's also a place then for a more covert way to collect data on compliance at the right time. And a couple of the other ways that I jumped ahead. This is a study that was published and presented at AGIC last summer using one of those hand hygiene observation tools that is iOS-based or Apple-based. And this study showed that they were able to get more covert observations, so they reduced the Hawthorne effect. So they compared hand hygiene compliance when staff knew that the infection prevention was watching them versus when they had trained volunteers using this iOS-based device. And they found a significant difference in compliance. Staff were much more compliant when they knew they were being watched by other staff than they were when they didn't think anyone was watching them. It also gave them the ability to, this particular device, this hand hygiene observation tool, gives them the opportunity to monitor technique and timing. So it has a timing app on it that can tell you if they've washed their hands for 15 to 20 seconds. It also can monitor PPE compliance, and then the data ends up on a secure reporting portal. So there are advances being made in tools to help us with direct observation. The other method for measuring product use is, the other method for measuring compliance is measuring product use. And so this is an indirect way based on measuring soap and antibiotic or alcohol-based hand rub consumption. And so it's a method that can be used, it's a proxy for hand hygiene compliance. There's a mathematical model that's used so that you can figure out how many hand hygiene opportunities there were versus how many actual events there were. It's less resource intensive than direct observation. It is possible to do it manually or electronically. It can be done in a variety of healthcare settings. One of the disadvantages is that it's not possible for you to distinguish healthcare hand hygiene practice among healthcare workers. You can't tell by role. You can't tell by time of day. You don't get any real good specific data about who's doing what, how they're doing it, which units are better than other units. But it does measure, and it doesn't measure the 5 moments. So it's only measuring product consumption, and you really don't have any idea if all of those opportunities were exit, or if some were entry and exit. You really don't have any way to know when the hand hygiene is taking place. And then the last method is electronic monitoring, and there are several different types of monitoring devices on the market today, and they use different types of electronic sensors and different technologies. The advantages to electronic monitoring is that it's designed to ensure that healthcare workers perform hand hygiene prior to patient care, and it may issue an automated notice to do so. Some of the badges will vibrate or flash or give some kind of an indicator to help change behavior in the healthcare worker in real time and give real-time feedback to healthcare workers. And many of these are also integrated into a database that allows for automated reporting. Some of the disadvantages are that some of the technologies can be expensive and have high maintenance costs. They might make it necessary to work closely with engineering to look at possible interference with other equipment in your hospital, so you have to be sure you're thinking about where you're placing these and if it's going to interfere with other sensitive electronic equipment. Some technologies connect to the hospital network itself, and in that case, then they may overload the network. And so these are all important considerations to think about. And I put this slide together that talks about some of the variables you need to think about if you're going to evaluate an automated hand hygiene compliance system. The first 4 are pretty easy to understand. First is cost, because we know sometimes these electronic systems can be costly. Accuracy is obviously critically important. The reporting capability of it, what kind of reports can you get out of it? Is it easy to get the reports out? Is it easy to show them to other people? How easy is this to install in your facility? Does it do individual monitoring versus group monitoring? Is it important for you to know that Jane Doe is doing a good job, or you just want to know that the nurses on 5 East are doing a good job? So that's the kind of question you have to ask. How many hand hygiene moments are monitored using this method? What's the monitoring area that's covered? Some electronic hand hygiene compliance monitoring systems have the ability to monitor at the patient zone level. So they're looking specifically at the patient bed versus the entire room. So if you have a patient in a double room and you can monitor by patient zone, that might be an advantage. What's the hospital IT requirement? Because that's a really big issue. If you can find a system that doesn't require connecting to hospital IT, that might be a benefit to you. A couple of other things to think about is if there are batteries involved, what's the battery life of the different devices that you're using, and what are the maintenance requirements, and what are you going to be asking of your facilities team if you implement this system. So all important considerations, but I would say that electronic hand hygiene compliance monitoring is very accurate, it's very helpful, and it can be very useful if you can find one that meets your needs. So then I would just want to talk a little bit about measuring environmental hygiene compliance. So there are methods out there, and many of you are quite familiar with these, I'm sure, already. In 2010, the CDC adopted a toolkit called Options for Evaluating Environmental Cleaning. And in that recommendation, they focused on cleaning high-touch objects. They say that we should be able to perform objective monitoring on the thoroughness of cleaning and not subjective information, that we should be able to provide continuous feedback that drives education and drives improvement, and that you should have the ability to develop reports so that you can share it with the staff, with leadership, and make it available to surveyors. So in that toolkit, they outline the 4 different methods of monitoring, and I'll go quickly through each of those methods just to sort of compare and contrast them. The first one is the total aerobic bacteria count, or culture. And environmental cultures are used to measure the amount and the type of pathogens on a surface. So it's very reliable, it's very specific. It's going to tell you exactly what's growing on the surface. And we do use environmental cultures in outbreak investigations or in other situations where we need to know specifically what organisms are growing on a surface. And the way it's done is in the case if you were going to use this for environmental monitoring, you would take a culture before cleaning and you would take a second culture after cleaning, and you would look at a reduction in organisms on the after cleaning culture that you took. The downside of this is, as you know, if you put cultures take probably at least one, probably 2 days to incubate, and so there isn't really the opportunity for immediate feedback when you use culture. But it's very accurate and specific. The next method is ATP, or adenosine triphosphate measurement, and that's the measure of organic cellular material on surfaces. And the method to do that is a swab that's taken before cleaning to measure the baseline organic material on the surface, a second swab taking after cleaning to evaluate how much of that organic material was removed. The advantages of this is you get a quick result, you get a number that tells you the number of relative light units on a surface, and you can get that result instantly so it can be used for teaching. It's very helpful for teaching purposes. I want to talk a little bit about ATP in healthcare, though, and put it into a little bit of context. ATP was originally designed for industrial use in the 1970s for commercial food preparation, and it was designed to be used on very clean stainless steel surfaces. And in that situation, the way they clean in food processing is they use high-grade disinfectants, and they flush the surface with a high-grade disinfectant, and then they flush the surface with water, and they test with the ATP monitor immediately after cleaning and just before use. And they're looking for a result of 0 relative light units. So it's a very binary process. It's either 0 or anything above 0 is not acceptable. And so it's used in food processing because they can't have any contamination of organic material on those surfaces. And the way they clean by flushing is good for that type of method. In healthcare, we use a different disinfectant process. We wipe surfaces, but we don't flush them with water, and so we're not completely removing the dead organic material that was killed by the disinfectant that we applied. ATP measures all organic debris on a surface, whether it's dead or alive, whether it's microbial or non-microbial. And so it's going to give you a number of some kind, and you're not going to be able to expect a 0 relative light unit reading. And in the healthcare industry, we haven't established a standard number, whether it's 250 or 500. There haven't been any guidelines set to say what the right number is that's acceptable for an RLU reading on surfaces. And so it's an important thing to know that it was designed originally to be used as a highly sensitive test that would give you a basic reading of 0 relative light units, and its adaptation to healthcare has been a little bit more challenging in some cases. Visual assessment is a qualitative way to evaluate the thoroughness of cleaning. So it's my opinion, my visual assessment of the visible appearance of cleanliness. This is the traditional method that we used for environment of care rounds. Observations can be either overt or covert. It's hard to watch someone cleaning and have them not know it if they're turning over a patient room. And so more often if you're observing someone clean, it's going to be known to them. It's going to be overt. And so your room might turn out cleaner because of the Hawthorne effect again. Because it's a visual assessment, it's limited to visible soil, and so it can be subjective, and I can't see pathogens, so I can't really tell if the surface is clean. So visual assessment will always have a place because we have to make environment of care rounds. We have to look for broken equipment. We have to look for scuffed floors. We have to look for gross soiling that's being missed. But if you want to actually know if a surface has been cleaned, this probably isn't the best method for that. And then the last method is a fluorescent marker. And so this is an objective measure of the cleaning process. So this is telling you whether or not a surface was cleaned. A clear marker is applied to high-touch objects after cleaning is completed. And then the marker is reviewed by an auditor with a black light after cleaning. And really you're just looking for that mark to be removed. Complete removal of the mark is a pass. If the mark is still visible at all, it's considered a fail. Some fluorescent marker systems come with, again, an iOS-based app that then uploads into a reporting portal where you can get access to your reports and share them with your staff in a really nice formatted way. But the point of this is that you're using this fluorescent marker to really evaluate the thoroughness of cleaning, whether the process of cleaning took place. And so it's a good objective method for that. Environmental monitoring is effective. So here are just a couple of studies to show that doing environmental monitoring does have an impact. This particular study was done in the operating room. It was published in 2012. So they did a prospective study. They used feedback with both fluorescent marker and environmental cultures. And they found that the percentage of UV markers cleaned increased from 47 to 82%. And and at the same time, gram-negative bacilli decreased from 10.7% to 2.3%. So they put in a system of monitoring and feedback and training, and they were able to show that as cleaning improved, environmental bioburden decreased. And this was an operating room setting. This second study is really just to show that not only does environmental monitoring improve the thoroughness of cleaning, but it also decreases the acquisition of pathogens, which is the most important thing we're looking for. This has an impact on patients and reduces infections. So in this study, in 10 ICUs, they used a fluorescent marker, cleaning cloths that were saturated with a disinfectant, and increased education. And they found that as cleaning improved, the acquisition of MRSA and VRE was decreased in the patients that were in those rooms. And so a really good study that showed that environmental monitoring has a patient impact, and that's very important. That's what we're looking at. That's the most important thing we're looking for at the end of the day. So this is my last slide. In summary, I'd like to say that hand hygiene and environmental hygiene are horizontal infection prevention strategies that are effective against a broad range of pathogens and infections. There's a constant transfer of pathogens between the patient, the healthcare worker, and the environment that we strive to minimize. We strive to break that chain. We know that FDA-approved hand soaps and alcohol-based hand rubs, as well as EPA-registered disinfectants, are effective if they're used correctly. And we know that human factor impacts the effectiveness of these horizontal infection prevention methods. And so monitoring hand hygiene and environmental hygiene compliance can provide information that will help you drive behavior changes and hopefully improve outcomes for your patients. And it's going to be important as you're looking at these monitoring methods to understand the advantages and disadvantages of each of those methods so that you can choose the right method for your situation. And so I hope I was able to give you some information today that was helpful for you to do that. And with that, I'll stop and see if there are any questions. Thank you very much.
Yes, thank you, Linda, for that fantastic presentation. As you mentioned, we'll now begin today's question and answer session. Everyone in our audience, if you have any questions, you can submit them by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll try to have Linda get through as many questions as we have time for. To start, Linda, the first question is, Are there any electronic monitoring technologies that monitor more than just entry and exit from the room?
That's a really good question, and that's been a really big challenge for electronic monitoring. And so a lot of the electronic monitoring technologies today really are at the room level. There are becoming more and more, and there are methods out there today where you can monitor at the bed level, so that if your patient's in a double room, there's the ability to monitor at the patient zone level. And so you're getting a little more detailed information, and you'll be able to tell if the healthcare worker leaves the patient zone and comes back in again, that it's an opportunity to do hand hygiene. I don't know that there are any electronic methods available today that are going to capture all 5 moments, but they're getting better all the time, and hopefully that will happen soon.
Perfect. Thank you, Linda. The next question would be, off of all the methods you mentioned to improve and promote hand hygiene compliance, have you personally found one to be the most effective?
Wow, that's a big question. Which method is the most effective to promote hand hygiene compliance? I don't think, so this is my opinion, I'm going to go on record as saying this is my opinion. I think we have to do training and retraining, but I do think administrative support from the top down, along with all the other things that you do, is a really important measure. If people see that it's supported from the top down, I think it's going to be very effective. And then I'll just say also that whatever method you choose, you have to be able to monitor what the impact is. So if you're monitoring hand hygiene compliance and you know that the nurses on the evening shift are not complying as much as others, let's just say, you can focus your effort there. And so the monitoring itself can help improve compliance because it can help you focus on the problem areas.
Great, that makes sense, Linda. I know that was a big picture question.
Yeah.
We have some audience members asking if there's a chance to obtain the presentation link or slides. Yes, there is. In about a week following the webinar, we will send you a copy of the presentation in the email that you used to register. So those will be available to you in about 1 to 2 weeks. Let me scroll through these questions, Linda, to get you the next one. This says, during our hand hygiene initiative, we have discovered that improper glove use is our biggest barrier. People think that glove use is a substitution for washing.
Oh,
have you dealt with this before?
Yes, that is a good question, and that is something that I know is a challenge. People think, and so that goes back to the health belief model. If you think about it, those gloves are protecting the healthcare worker. They're not necessarily protecting the next patient, and so they are using those gloves to protect themselves, but they're not really thinking about the whole picture and thinking about the fact that if they take these gloves, they're not protecting the patient or the next patient. I know that there is a hand hygiene observation tool that includes questions on, if you're doing direct observation, that it includes questions on proper PPE use. So for instance, it'll ask you, excuse me, what type of isolation the patient is in. And then it will have you answer questions about, did they wear gloves, did they wear gowns, did they wear masks? And it can give you some feedback on compliance with PPE. But it is a problem that I've run into, and I do feel like it's a little bit of a, I'm taking care of myself, but I'm not necessarily worrying about the impact on other people. And so maybe the method to change that is to try to give them get them to think outside of themselves a little bit more. And maybe it's those things like personal stories that help people think about how this infection impacts other people. I don't know if I answered the question because it's a tough one. A lot of the challenges with hand hygiene compliance are really hard to fix, obviously, or we wouldn't still be talking about it all these years after Semmelweis. But whoever invents the way to make people wash their hands will be very rich.
Thank you, Linda, for answering that question. Looks like we have another one from the audience, and they are asking, are there any study templates that you recommend to use if we are not using electronic monitoring?
Study templates. Is that the right word? Study templates?
Yes, correct. Study templates.
I don't know if I have a ready answer for that. I'm not sure if I exactly understand the question, unless it's like a checklist that they're looking for. Maybe my email address is up on the screen, so if the person who asked that question would just want to shoot me an email and just expand on that a little bit. I'll try to help.
Awesome. That's great, Linda. Thank you. And it looks like we have time for just about one more question, so I will go ahead and ask that. Are fluorescent markers meant for specific surfaces? We have had difficulty removing them from some surfaces.
They are not really supposed to be for specific surfaces. Fluorescent markers, if they're designed correctly and used correctly, should be able to be used on any surface. I will say, well, with one exception, you don't want to use a fluorescent marker, and I'm only going to speak for DAZO fluorescent marker, which is the one that Ecolab has. But it's not intended for use on soft surfaces like fabrics. It's not going to, because it won't come out. It's intended for use on hard surfaces. But if you're using it on a hard surface, it really should come off without any challenge. It's designed, at least DAZO, it's a water-based solution that's designed to be easily removed from hard surfaces.
Thank you so much, Linda, and all of our audience members for attending today.